Okay, regarding the examination of the back, as we have learned from the anterior chest examination, we have here a posterior cheek examination. First of all, we have to inspect and then to palpate, percuss, and lastly we have to auscultate in the following manner. First of all, you have to inspect both areas in the back for symmetry, shape, the expansion, and listen for any heard sound, and you have to detect the intercostal recession for dyspnea if the patient is dyspneic. Also listen for any wheezes, for any stridor if the patient had, or if he or she had a prolongation in his expiratory phase. After that you have to palpate. Really we have 3 steps in the palpation. First of all about tenderness, and then vocal frimitus, and then chest expansion. First of all I should ask the patient about an area of pain. أكو مكان يوجعك بظهرك. Okay, then you have to detect it. أكو هسه وجع هنا هنا هنا. Also you have to choose upper and lower zones in the axilla bilaterally. After you detect that there is no pain, you have to check for vocal frimitus in the following manner also. 44 كلهم. هسه 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 هسه. أشتبك. After that you have to detect for chest expansion in the following manner. First of all, try to detect the spinal process number 7 after asking the patient to flex his neck. This is the C7, below which T1, T2, T3, 4, 5, 6, 7, 8, 9, and here is 10. You have to approximate your thumb in the midline, slightly elevating it, and ask the patient first of all to exhale and then to take deep breath. هسه ذبلنا نفس كلش قوي قوي قوي، ذبه ذبه عشت ايدك. هسه اريدك تاخذ نفس كلش قوي عشت ايدك. هاي okay, this is هاي على راحتك. So this is the expansion, or this is the difference between inspiration and expiration, and I'll check it how much. It is about 7.5, the difference between inspiration and expiration. So the chest expansion is 7.5, which is normal, because normally more than 5, more than 8. If it is below 5, it is abnormal, definitely abnormal if it is below 2. All these issues about the palpation, and then we have to percuss. As we have learned previously, you have to percuss multiple areas in the back, also include the axilla with you, and you have to instruct the patient to perform the following maneuver. And you have to percuss in the intercostal space multiple areas. The percussion note should not extend beyond T10, because T10 is the lower borders of the lung. After that you have to detect upper axilla and then lower axillary areas or lower axillary zones. After the percussion have been completed, and also the same issues, the same finding of that of the anterior chest, you have to check or auscultate the back of the patient, and also ask the patient or tell him about the instructions that he should breathe from his mouth, not so deep, not so fast, and you have to auscultate in areas that is not close to 3 centimeter from the midline. هسه حماده نفس الحالة، النفس على راحتك، مو كلش قوي ولا كلش سريع، تاخذه من حلقك مو من خشمك، ومن أقول لك أنا نفس بعد 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 قوي قوي بعد قوي بعد بعد. Okay, after that, once you complete the auscultation, you have to ask the patient about the to say in Arabic 44 for the vocal resonance. Vocal resonance the same as vocal frimitus. Instead, beside that we use the stethoscope. بس حاليا 44 بعد بعد بعد. Okay. you should continue and listen over all areas of the back, but because he is a volunteer, I'll omit intentionally, I'll omit the rest of the back. Really, during the examination, if you find an area of consolidation, for example, and so on, and you detect that the patient had a bronchial breathing, you have to detect whether the patient had agaphony or whispered bacteriology in the following manner. For whispered bacteriology, listen over the abnormal area, that of bronchial breathing, and ask the patient to whisper something. I'll ask him to whisper one, and then in the same tone, the same word, I listen for over the normal area for comparison. If we suppose that this patient had here an area of bronchial breathing, I'll perform the whispered bacteriology in the following manner. حمادة أريدك بينك وبين نفسك همس تقول واحد، قول لنا واحد، أوكي بس همس، أوكي يلا قول عشت ايدك هسه، okay, and compare both areas. Usually over the consolidated area, over an area of a bronchial breathing, the whispered sound will be perceived and heard louder than the normal area. This is about whispered bacteriology. And about agaphony, the agaphony asks the patient to say in the following manner. I'll auscultate over the abnormal area, as we suppose this is the abnormal area, and here over the normal area also for comparison. Ask the patient to say the heard sound. If it is truly bronchial breathing, you will hear nasal in the following manner. You ask him to say you will hear okay. هسه حاليا نقول لنا بعد. Okay, you have to compare between these two areas. This is about agaphony and whispered bacteriology. What is there to us from the back? Sometimes the examination committee asks you about the diaphragmatic excursion. Diaphragmatic excursion is performed in the following manner. You have to percuss from above the chest, from the back of the chest downward on the right side, because this is the site of the liver here. First of all, ask the patient to exhale breath. When you reach area of dullness, then ask him to inspire air and detect the difference between expiration and expiration. This difference should be more than 4 to 5 cm and indicate that the diaphragm is ascending up and down during breathing. هسه اريدك تذب لنا نفس من صدرك وتبقي صدرك فارغ. يلا تذب لنا حال. اقطع نفسك طيب. Okay, this is an area of dullness. هسه اخذ نفس كلش قوي وحبسه بصدرك. Became resonant. Now it is dullness. So the difference is that على راحتك هسه خذ لك نفس. It is 7 centimeter between inspiration and expiration, and this is the diaphragmatic excursion. Really, you have to present your finding according to the zones and according to the lobes of the lung. How we can know the zones of the lung? From the back, we have upper zone extending above the T4, and we have middle zone extending from T4 to T7, and we have lower zone from T7 and below. In the axilla, you have to choose an upper axillary zone and lower axillary zone. In the anterior chest, we have the following zone. The upper zone extending above the sternal angle or second intercostal space or second rib. Above it, this is upper zone. Below which is the middle zone up to the fourth intercostal space. Below the fourth intercostal space is the lower zone. So we have upper zones, middle zones, and lower zones. Really, this method is not so accurate. It's just for a clinical presentation of finding. We have to know the other more accurate method, which is presentation according to the lobe. From the T1 or C7, C7 spinous process. Here is T1, T2, T3. From here, a string is extending from the back, crossing the axilla, crossing the axilla from here, if we follow this line from here, and then approaches the sixth rib anteriorly. This string will divide the lung into lower lobes and upper lobes. This is with respect to the left lung. And the right lung, when this string extending from T3 up to extending from here, from T3, crossing the axilla into the sixth rib here. This will classify the right lung into lower lobes and here the upper and middle lobes. How we can know the upper and middle lobes? Really, from the fourth rib, you have to have an imaginary line from the fourth rib into the fifth rib in the mid-axillary area. This line from here to here, from the fourth rib anteriorly into the fifth rib in the mid-axillary area, will classify the right lung into upper lobe, middle lobes. So in the right we have upper lobes, middle lobe and lower lobe, while in the left we have lower lobe and upper lobe. These strings are called oblique fissure, the large string one. In the right we have the horizontal fissure. All these about the examination of the chest from anterior view and from posterior view, and I am greatly thankful for your listening.